Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and this episode was recorded at SOMSA 24 in Raleigh, North Carolina, with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
There we go. All right, you can bring that up. So we're going to discuss a little bit about what is a potentially controversial topic within the audience here, and that's why we're bringing it up and why we really need to talk about this. I'm Harold Montgomery Monty with the JTS and the Committee on TC3. Have several member panel of experienced medics and docs that are going to answer some key questions as we go forward here. Where's the slide thingy? All right, so up front, our usual disclosure. This is all going to be very personal opinion and not representing DOD or any of the units or anything. All right, and then up front, very cautionary statement here. So as we start talking about some of these topics, this may be a trigger point for any of us in here as we've dealt with casualties, potential situations, either on a personal family side with a family member or in the combat setting, that kind of thing. So caution is advised to anyone who might have that. At the same time, we want you to engage in this right now. So that little QR code down at the bottom, if you want to hit on that, we've been advertising this through the week. This is a survey that we're doing to get a little bit more information on experiences out there to discuss end-of-life care, expectant care, and where we're going with this, and get more and more feedback as we develop the CPG. So this should be up on all the slides. If you don't get it right now, it'll appear. So what is it we're talking about? What is expectant care and end-of-life care? So you can see definitions here that we have toyed around with these words for the last few months of exactly what we want to use, what we want to say. This is pretty firm jello right now as we're moving forward with these terms. That being said, there's always room for change, room for edits, but trying to get this to a firm thing. With the expectant casualty care, that care provided to casualties in a Role 1 setting. So that's one key point we want to set out here. We're talking about Role 1 setting for whom further resuscitation is delayed or withheld as they are determined to have a poor chance of survival and or require significant resources. So those casualties that we, as primarily medics and Role 1 providers out there, have determined and triaged as this is a casualty that I can't fix, all right? I can't save ultimately, but if I could have evacuated, most likely could have survived. I mean, that's fundamentally the ones we're talking about here, that we're going to realize we're going to watch them die, and I can't do much about it. So how can I best manage that? And then subsequent to that is that end-of-life care, all right? The care provided for those casualties deemed obviously dying with the intent to alleviate the suffering. So, why? Why are we looking at this? Well, the reality is reality. Our potential future is World War II level conflict and casualties, and they dealt with this before. And can we pick up where they left off and do this again? It's not something that has been overly common at certainly the Role 1 level for the last couple of decades. Role 2, Role 3 has dealt with this, but many of them are experienced providers with that kind of thing, so it's a little bit different. Plus, we're just going to have all those mitigating factors of the list go, the irregular warfare, prolonged care. This all falls into place with this. Lots of factors involved here. I think through the discussion and as the questions are discussed here, we'll probably hit on a lot of these little pieces. But if you think about it, just looking at that big, bold psychological care factor, there's a lot of facets involved with that. The casualty, who potentially could be conscious through parts of this and dealing with this. There's the provider, the medic, who is dealing with the situation and what they have to do or withhold. There's the team and the platoon, the unit around them that is going to be dealing with the situation. And then because we are all such a close-knit group, potentially the family of that casualty weeks to months later as well. So it's all the same factors that you see in any end-of-life care situation, even with elderly and that kind of thing. All those pieces that fall into play. Granted, those providers, they do it for a living. So if you're talking about hospice and that's what they do. We ain't hospice people. This is potentially once in a lifetime kind of thing that we're dealing with and dealing with the whole situation. The triage, triage is going to play such a critical role in this, and it's one of the key reasons that this is happening is because we had to triage a certain way. And then the management. So we're going to touch just a little bit on our draft management concepts here, and I think we'll probably discuss that a little bit further as we go along anyway. All right. This is going to be critical role down at unit level and medical director level, where hopefully taking what we discuss here and taking that back to the units and really discussing that back there of how are we going to deal with this kind of situation when, one of our buddies is in this. Either how am I going to deal with it as a medic and with one of our casualties and that kind of thing. So there's got to be a strong appreciation of the training lack of across the board. I think in soft circles we've at least touched this a little bit, but your junior medic corpsmen out there, this is a PowerPoint slide, and that's about it. They're not really getting true training that you want to call. And even we'll talk about it here in a moment, but even at the soft level, we could get this to more intensity at the training we're talking about. We're going to deal with this, whether we have a delayed evacuation or we're flat out told there's not going to be evacuation. This situation we're going to deal with in the prolonged care situation and deal with these kind of casualties. And then, like I said, the teaching and prepping for the management of the casualties, and then this being kind of a before, during, and after mission set. So, when you're going into the mission, how are we going to deal with this if we have to? During the time that you're dealing with it, and then post-mission as well. I believe we're going to have a lot of issues. What kind of conditions are we talking about? And this is just kind of our first scrub up front list. Obviously that massive injury or massive hemorrhage that's already gone into shock. We've already tried all of our shock resuscitation protocols. We're getting low on blood. We've dumped a lot of blood into them. We've dumped a lot of effort into them, and we're having to make that decision, of they're going to need a lot more. They're going to need a lot more blood. They're going to need a lot more surgery or things that we can't do in the field. Obviously, the devastating neurologic injuries, and then the severe burns. That anybody who's dealt with severe burns, you see them progress over that time. That they don't look so bad initially, but a few hours later, they're much worse, and then much worse, and much worse, and you're only going to see this whole situation get worse. The medications. So in our kind of classic view on this is the minimum, better, best. What can we look at with just what we have in the TC3 bag, and then stepping that up to, a little bit more potentially. And this is where we, need to relook the morphine and things like that. Is this something we may still have to carry? Maybe not in the initial TC3 bag, but somewhere nearby. And then certainly going into that best care where we get into a lot of the different kinds of medications where we're a little bit more prepared for this, but hopefully not getting to a point that we're carrying the drug to put someone down. That's not the intention. Anything that we're talking about should be things that we're going to use for other conditions as well. All right. So our panelists, I'm the moderator. I'll just go down the line and let each of them do a 5-second intro of themselves, and then we'll jump into the questions.
Hey, good morning. I'm Sergeant First Class retired Paul Lose, just retired after 20 years, 10th Special Forces Group, the Schoolhouse, and the Office of Special Warfare.
Hey, good morning. Master Chief Justin Wilson, go by Willie. Currently the Senior Enlisted Advisor to the Joint Trauma System, spent a career with MARSOC, and I am a SOIDC.
I'm Rick Caldwell. I'm the Senior Medic for 10th Special Forces Group and have been doing Special Operations medicine for about 21 years.
Good morning, everybody. Sergeant First Class Wickerham. I'm the 75th Ranger Regimental Training NCO.
Colonel Retired Sean Keenan. I'm an EM and an EMS doc, and I'm representing the medical director's standpoint.
Matt Tadlock. I'm a trauma critical care surgeon, so I'm representing that side of things. I chair the Committee on Surgical Combat Casualty Care, and a lot of our CPGs fall under that committee. And then I'm currently at 1st Medical Battalion at Camp Pendleton.
And I'm Young Yeager. Yeah, I'm a combat nurse anesthetist that served several times out in Afghanistan and Iraq. And I'm the current executive director of a grant agency.
All right, so what we'll do is I'll pop up a question. I'll tag a couple of them. They'll do about a 2-minute response, open it up to any of the other group. And we have a short amount of time. We'd really like to have some interaction with this. So we'll run through us with the questions and then open it up to the audience if you have other questions or if you want to have your own input to these as well. So first question, and I'll address this one to Sean and Young. Have you ever experienced expectant casualty care or end-of-life care during your career? And then describe the situation, and did you have any personal injuries and concerns and that kind of thing as well?
So as far as expecting casualty care, truly triaging somebody, not true to the definition, but during my training as an emergency physician, we had folks that came in, people that would have been deemed now what we call hospice, who actually, as a team approach, me as a young resident, medical students, staff around me, we had the opportunity to provide care where people died in the emergency department. But we were able to do that in a structured way. We could have some learning after the fact, and that's how I learned it. As a medical director in Afghanistan, I had one of my 18 Deltas call me up, said, "Doc, we're about to run out of oxygen. We have a 12-year-old girl that has severe brain injury. We criped her. She has a GCS of 3, and we've been sitting on her all night. We're about to run out of our oxygen." And I was like, oh my gosh. And the whole team's invested. Some of them have 12-year-old girls at home. They're invested psychologically. And I told them, I said, look, there's nothing we can do for that. The rules of eligibility as established says we cannot evacuate this person to a U.S. hospital. I said, it is my call. You write this. You tell them, Doc told them, you need to let that girl go home. You need to withdraw care. You guys did everything you could do. I absolutely appreciate where you guys were doing everything you could. It is my responsibility, I'm telling you. Withdraw care. Use the term inshallah, send this girl home. They see how much you care. And so, as a medical director, I basically advised my guys, withdraw care on that patient. That was a tough one.
So, my situation, I have actually engaged in end-of-life care, specifically with patients that I received in Afghanistan. In this particular situation, it was a traumatic brain injury from a high-velocity gunshot wound to the skull. The patient was not conscious, so it made it a little bit easier. We had already gone through a mass cal situation, and we were lower on supplies. The physicians spoke to me and discussed about giving pain management for the patient and making sure that the patient was comfortable during that period of time. And there was some conversation about bioethics and things. Ultimately, in the end, I made the decision, since I'm the anesthetist, I need to manage the patient appropriately so the surgeons could take care of the other patients. I ended up giving that patient, oh my gosh, I think it was a tremendous amount of ketamine, also some fentanyl, over about an 8-hour period of time until the patient finally expired. During that period of time, it was just really difficult because the patient was having reflexes and was able to respond to noxious stimuli. But clearly from the gunshot wound, if we were perhaps in the United States, the patient could have survived because this was a supratentorial wound. But because of the situation we were in Afghanistan at the time, we knew that it was a futile effort. So withdrawing care on that patient was really challenging for me. We have this sense that we want to try to save as many people as we can. But in this particular situation, it was just so unique, and it affected me. It really did, to the point where it makes me think that, am I going to get judged for this at one point because I allowed this individual to go through this process, or is this just something where I've got to chalk it up to grit and resiliency, and I just put it in a little closed area of my mind? So that's my personal experience I'd like to share.
All right. We'll jump on to the next question here. So I'll direct this one to Willie and Paul. So medic-wise. So in your opinion, has your training prepared you for ECC and EOL care and in the anticipated just simply a deployed environment? So just as we are right now, or as we've been the last 20 years, have you been trained for this kind of thing? So.
No, I don't believe we have. Obviously, Paul and I were both classmates going through 18 Delta, so we have a higher thought process of things. But when we talk about, like, on the conventional side of medics, I don't think they have anything like that. They get told that they're going to say, hey, doc, or corpsman up, and you're going to run out there and you're going to save your lives, because that's what you do. We haven't prepared our medics and our corpsmen for what General Donovan talked about on Tuesday about people are going to die. We have to be prepared to accept that people are going to die. And then how do we take them into that death process? How do we deal with all that? So I don't think that's really been addressed at our level, on the enlisted levels at all.
Yeah, I couldn't agree more. As a 68 whiskey, I had a patient in northern Iraq who had survived an execution attempt. And so taking care of him, he was still alive 45 minutes after when he got to us. After doing the March algorithm, I got down to about C. So I noticed the coup de grace that didn't finish him off. And so I was still trying to take care of him. By that time, the helicopter had already been called. They're on the way. We tried to rush to get him to the aid station, but at that point we knew it was futile. But at some point, never did it cross my mind to check his vital signs to see if he was experiencing pain and to be able to alleviate that. So I'd say the training in that sense did not. And so now what we see in training, when we put guys through, we put hundreds and thousands of guys through different training scenarios. We always give them survivable patients that they have to deal with for a long period of time, but we also throw in patients that they can't deal with. What you see is a wide swath of variability in care, if they give any care at all. A lot of times in training, expectant patients end up around the corner, and that's about the care that they receive. So if you don't train somebody and actively encourage them to address that situation and change their behavior, they're not going to do that when the time comes, when the stress is really high.
All right, Paul, can I ask? Because I think we talked about that case before. You said when the helicopter was called, did you call the helicopter?
No, it wasn't me. I was totally in and down on patient care as a 68 whiskey, E4. There's the whole other platoon that was trying to spin up assets and resources. So by the time it was on the way, it was already, I wasn't even aware.
So the disposition of that patient was outside your control. Somebody else was telling you where that patient was going to go. Or conversely, could have told you, hey, you need to stop caring for that patient because operationally we need to move out. They're not one of ours. So in these situations where a medic is doing exactly what they're trained to do or exactly how they feel in line with their values, and now somebody else is making a decision which is contrary to either the medical indication or perhaps the values. So for instance, could Paul have done more? Or did Paul say, hey, I wanted to save my splice for my guys, yet somebody else is overriding his triage decision or disposition decision? So you can actually have some kind of a conflict there, some moral distress. Okay.
Yeah, and I believe that was just from, that was habit. We try to save everybody that we can and do the most for every single patient. So they were, doing the right thing in their eyes. Yeah.
All right, so this next one I'll address to Ben and Rick. Has your training prepared you for the LISCO kind of environment of dealing with this, where it may not be one that we're talking about, but several, and over a long period of time?
So I think the answer is a two-part answer to has my training prepared me on. So as a special operations medic, I feel confident that in the moment I'm going to make the best decision for me and for what I think the patient needs. At the same time, we're not at the place, as we all know, where a protocol is designating the type of care that's expected. So my concern, and thanks to Colonel Keenan and the passionate conversation we had at the COTC meeting in February, the conversation I think we need to have is normalizing the discussion, having top cover from medical direction that empowers medics to make decisions, and then also having a conversation on how this translates to a conventional force. Because I think ultimately the ethical decision is going to be passed to the medic or whoever is making the decision at POI. And I think that's where we're falling short currently.
Yeah, I completely agree with what Ben's saying. As senior medics, we've all been trained pretty well to make good decisions. However, many of us, or many of the guys out there, haven't actually had to deal with end-of-life care, having
multiple MLS Afghanistan trip where it's like, cool, Afghanistan civilian that had an IED strike, multiple injuries, air is black, so we're not being able to evac this person, making them as comfortable as I can, knowing that this person's going to die. Or later on in that deployment, having teammates and partner force guys in a mask out. It's like, cool, I'm terminating care on this, though, all these ones, because I know that we're not going to be able to make them survive past evac, let alone anything else. It's now not just what can I do, but what should I do? And that's a big question that we often aren't discussing, which is going to lead into more injuries and other things, because at least in my experience over the last 21 years, the vast majority of the times I've been given patients that are dying or die on me in training, it's because I was making mistakes. So now patient death is associated with me making mistakes, not battlefield injury or issues that are associated with just combat in general.
Monty, can I take another 2 seconds? So another thing I think the Ranger Regiment does well, and it's not a perfect solution that's applicable to everybody, is that we're comfortable having internal ARs with ourselves about performance. And that normalizes candid conversations about expectations and what we can do. So again, with empowering leadership, guys feel comfortable saying, I wish I would have done this differently. Another thing we do well is we train casualty volume beyond the resources that we currently have, which I think at scale is what LISCO is going to be. It's going to be a volume of casualties that is disproportionate to the resources you have to treat them. Where I think this conversation is appropriate is that proportionally, this conversation is not practical for a golden hour context environment, and I think everybody agrees with that. But if we're talking about LISCO and you're asking me to be, if you're asking me to train for a mentality that is a proportionality that we're not used to, we deserve having a proportional conversation about what that reality is.
Yeah. One other thing with that too, that we've all talked about PFC, PCC being the outside of doctrinal norms, which for the last 10, 15 years, our doctrinal norm for evac has been the golden hour, 1 hour standard. When we go to LISCO and we're looking Ukraine, we're looking 7, 10, 15 hour standards of evac, and that's going to become our doctrine. Every patient's going to be a PFC patient or a PCC patient. It is going to increase our risk or increase our prevalence of having those end-of-life patients at the roll one with the medics dealing with that.
Okay, moving on to question 4, and I'll direct this to Matt, Sean, and Young, because we're kind of looking at a little bit more strategic level and where it's been done before. So what obstacles do you feel will become problematic with strategic implementation of expected casualty care and end-of-life care CPGs if we truly do go down into making a guideline of this? So go to Matt first.
I guess I'll take this one. And my answer may just go into question 5, I guess. So, so as a trauma surgeon, we make end-of-life decisions in the trauma bay and the operating room, and then later on in the ICU. We do it all the time. And I remember the first time I lost in the trauma bay and I had to make the call to stop, and I remember the first time I lost in the operating room and had to make the call to stop for various reasons. And it's hard, even with a lot of training. So that's my perspective from this. And then also the perspective of the CPGs. We at the JTS and the COS, we put out position statements, we put out CPGs, and the CPGs, to some, people go by those and they listen. They are the standard. And so from my perspective, you have to be very careful what guidance you put out there and how you put it out. And so that's my concern. And I've seen unintended consequences from some of the guidance that we put out, like our single surgeon team statement, the way it's interpreted. Everybody interprets things based on their own experiences. And so with a potential clinical practice guideline talking about end-of-life care, how we do it is we need to be very careful. And I'm more concerned, I'm going to steal a quote from a former medic. Well, let me step back. So I think what I've heard here from the group so far and the conversations we've had, how we train medics and corpsmen to deal with this on the battlefield is not adequate. Okay? And I there's no doubt in my mind that we need clear guidance that will hopefully impact training. But what I don't know is if you put guidance for the Role 1 environment, prolonged care environment, how to say, well, this is somebody who is maybe talking, maybe breathing. If you don't have the resources to save their life doing the standard thing, or aeromedevacum or whatever, we should then give them an algorithm how to provide end-of-life care to make them comfortable. That is a challenging thing. And the quote I don't want to put the person on the spot, but the thing that it's a time bomb of moral injury for the undertrained. So it brings the moral injury that we're trying to prepare on the front end, and it's just putting it to the back end. And so the way that I look at it, it's kind of like states' rights issue. I think we need to empower and train the medical directors and put guidance for the medical directors to handle this for their units how they want. Because I'm really concerned about the message of the JTS. The JTS is about saving lives on the battlefield. It's not about helping people die on the battlefield. Now, people will die on the battlefield. And how we help those forward deploy Role 1 caregivers, we just have to be very careful. But again, I think we need to, for the second half of that, how to do it, we need to train and empower the medical directors to get their teams ready for that, what's right for their unit. Because I don't think a one-size-fits-all CPG is the answer.
Quick comment there. But if you're trying to save everyone and you don't have clear guidance as to who is going to have a bad outcome, you may take resources being time, expertise, bandwidth, away from somebody who's potentially salvageable and use it on the worst case scenario. Wherein if somebody had that, so you're not optimizing limited resources to save the person who needs to be saved. So I would submit to you, although we're trying to save lives on the battlefield, we need to help identify those people who would most benefit from their direct care.
1,000% agree. And I'll tell you, when this process started, I wanted no part of it.
I know. That's
and that part is clear to me. 100% agree. And that's what I think the focus should be, is through guidance, through training, helping. Because what I heard yesterday, and I never heard this before, I guess it's pretty common. Far forward, you don't have a CT donut of truth, right? Like, you don't have a lot of information. So how do we prepare that person to do the best they can with limited information to know who to focus on and who not to?
Yeah. So then
which is triage in my
mind. If it goes to medical directors, now I've been a medical director like 4 times in the military before I finally got it right. I don't know if they kept sending me back until I got it right. But, bottom line is, okay, I am emergency medicine. I'm trained in this. You're a surgeon. We are putting non-trauma based specialties, young O3s, out and saying, be a medical director. How are they going to know how to train their people if we don't publish some guidelines?
Well, and that's why I think the guidance should be for medical directors, and this is how this may look on the battlefield. I don't want, and I'll say the quote again, for the junior guy or gal that's super far forward, who's 18, 19, 20, and I've not been that person, so I want to be careful what I say, but it's a time bomb of moral injury for the undertrained. The thing we're trying to prevent on the front end, we're going to give it to them on the back end. That's my concern.
Sir, as the guy that's been the 18, 19, 21-year-old dealing with those end-of-life care patients, I can tell you the moral injury that I suffered because I wasn't prepared and given a, hey, people are going to die thought process off the bat was far harder than when I became a senior medic and it was like, cool, I know how to deal with this and I know how to terminate life, end-of-life care, or treatment on my guys that are my best friends that I'm watching die. So not preparing them early and often is going to cause that time bomb to grow and detonate far larger, in my opinion.
So do you think that you as the individual need a CPG on how to handle those difficult situations, or do you think that needs to be a medical director guidance, the second half of it?
Sir, when we're looking, let's look back to Ukraine, the thing that's going on currently. the 68 whiskey equivalents, the junior medics, aren't reaching out to medical direction to make these decisions because they don't have time, they don't have resources of communication, and the EW environment in which they're working in precludes them from making those phone calls and radio calls. So they have to have it at the frontline level.
Shouldn't it be part of the mission planning on how you're going to handle this before you go out on the mission? Whatever you're supporting?
Yes, but where's that going to come from? A CPG. If I'm planning the mission, I'm looking into the CPGs that I'm expecting to have to implement on that operation. Whether it's end-of-life care, mass casualty, chem bio, it doesn't matter. I'm looking at the CPGs to remind myself, what do I need to pack for on this operation, as well as what do I need to prepare myself and my team for in the event of. Monty said this is going to be a once-in-a-lifetime event. I've had multiple already in my lifetime, and we haven't started LISCO.
I would just offer this as further investigation of this topic. It's truly just a cultural issue that we have within our military right now. We have so many disparate positions on this particular topic. And to your point, Dr. Tedlock, I think you need to have a ubiquitous approach that everyone appreciates end of life and expectant casualty care to a certain degree, right? To be able to incorporate it into that. And I'm not entirely sure if that's true, particularly with some of the comments that were made on the lack of training that's being offered to these individuals. And you had mentioned training to the untrained individuals. It's a time bomb. My question is that lack of medical expertise, or is that a lack of resiliency, or a lack of being able to understand and be trained to be able to tolerate those situations?
So I want for the medics on the panel, I think part of this is, and correct me if I'm wrong, initially through your training, the first time you had to deal with something like this, doing the structured interviews and all the work we've done, it was clear to me that if your patient died, that you failed. And you weren't trained how to understand that they weren't going to make it anyway. And that's what we have to focus on first.
Absolutely. Yeah.
Am I off base?
No, and so, sir, to be totally fair, if I'm in this situation in LISCO, I'm going to do whatever I think is right. And I'm not going to worry about what medical direction tells me, to be totally transparent. And again, that comes back to special operations basis of training and a foundation for me to adapt and overcome. But it's also because I'm willing to take the consequences on the back end. Another way to look at it, too, if we're talking moral injury, because I think that's a great point, is in the GWAT, even if the patient was going to have a poor outcome or was already expectant, determined at a medic level, there was some moral victory in getting to evac, right? Like, even if it didn't change the outcome, it's not going to make you feel better, but you know in a small way that you accomplished getting that person to a higher level of care, even if the outcome was poor. So in LISCO, though, you're going to be making decisions. The definition of what is expectant versus the global war on terror, and LISCO is going to be different, because whereas we had a predetermined end-of-life protocol for obvious signs of death or a pulseless apneic patient that's been confirmed, we are going to then essentially stop resuscitation, mid-resuscitation, on a casualty that years ago would have been potentially survivable. And so you're taking away the evac as a moral crutch or a moral tool for the medic to have some takeaway that he did what he was supposed to do. So in the moment, he's going to make the decision that he needs to make. The counter for the evac is now giving him a way to provide comfort, right? It is not going to change the outcome of that patient, but giving him an opportunity to provide comfort in a deliberate fashion that is empowered by his medical directorship is going to be the way that you help mitigate the moral injury. It's not going to take it away, but him having something to provide is going to be a reasonable compromise.
And secondary to what Ben's saying, it's not just the medics that we need to prepare for this. It's as medics, as docs, doesn't matter what level of doctor you are or what level of medic you are a medical advisor to your commander, whether it's the platoon, leadership, battalion, whatever. So when I'm telling my company leadership or my ODA leadership, this is what we're doing, we're going into palliative care, X, Y, and Z, and they're going to know we're saving everybody, and they want to see the policy, the doctrine, the whatever that says, I have the authority to make that decision. our 68 whiskeys in the vanilla, big army get those questions too. Well, what's the policy on that? What's the rule on that? And if they don't have one, you're setting that for even
and I counter, so is that a service responsibility or is that a JTS responsibility? I don't know, and that's what I'm struggling with.
So while the JTS is not a doctrine writing institution, it is a policy producing institution by the things that it puts out. And it is also, I believe, the DODI and has already stated that the JTS is DOD's healthcare SME, subject matter expert for everything we're doing, not just trauma, but everything, period. So if the JTS is putting something out, whether it's TTRIC is all we need to do, which that's not been put out, or we need to look at X, Y, and Z, that becomes the start of service policy.
One example, and I'll be quiet. This is a surgical team that we're starting to see a signal of junior kind of unexperienced people. Surgical team had a patient, thought they were going to get additional patients, and so they stopped. And they didn't get additional patients. And I don't know that the patient would have survived. That's what I'm terrified of. And I've seen it. I've just seen it. We've seen it at another level of caregiver. So that's where I'm coming from.
But there's a selection bias there because 96% of people that make it to a surgical team live. But if you have a mass casualty situation where half those people are going to die, we need some decision guidance there. And so the bar is set way higher if they make it to a surgical team, and they should be scrutinized higher. But when a guy has got 10 people around them and half of them are going to die, where do they even apply their skills to potentially make a difference? I would submit that we need to put some guidance out there.
And I agree with that, where I'm having issue with the next step. And after that, when it's a long time and you're running out of resources, how do you handle that? And maybe I would feel personally better if it was nested within a triage guidance or a mass cal guidance as opposed to a end-of-life care CPG.
So I think we've already stepped into quite a bit of panel's question number 5 here, is the unintended consequences about creating a CPG. So Matt, you already said quite a bit. You want to hit this one anymore?
No, I'll be quiet.
Okay, so I'll open this one up to anybody. And what I would throw out is and we touched on it just a little bit, is not the medical decision making, but the unit decision making that is going to have a role in this as well. So
it's not all medical. So one of the studies that's come out from Ukraine and elsewhere is like just getting into simple TTRIC stuff, right? Like the number of tourniquets that are being placed, the number of limbs that are being amputated that weren't medically necessary is close to 80%. 80% of the tourniquets being placed in combat, not medically necessary. However, I would also argue that they may be very tactically necessary. I have a decent bleed. I don't necessarily have time to evaluate that wound, put a good pressure dressing on. So I'm going to throw a tourniquet on. And then hopefully get back to readdressing and converting that later. However, that was a tactically necessary decision, not a medically necessary decision. And end-of-life care, palliative care is likely going to be in that position a few times. One of the biggest quotes and questions I remember getting as a Robin Sage student was from our instructor. And it's like, well, what's more important, the mission or the men? Unanimously, probably even in this room, the answer is almost always the men. The question becomes, what about when the mission is the men? And that was a Choson Reservoir quote, where it's like, hey, we have to leave people behind. We know you're not going to survive movement, but you're still conscious and able to fight. So to slow the enemy down on their advance, I'm going to maybe give you a touch of morphine. I'm going to maybe stop your bleed a little bit so you can be the cannon fodder to allow the rest of the unit to retreat. Those are both medically and tactically sound decisions that would be absolutely shot to shit and questioned every day of the week now.
I think aside from extraordinary circumstances where these things are happening, around the world, they've happened for 20 years. Medical directorship is variable at best. So, like, Commander Tavlock said, there's got to be training.
Absolutely.
Yeah, and it all goes back to something, Bob Mabry always said too, is who owns the combat casualty? Who owns this decision? Who owns this real problem? There's a lot of finger pointing, no real owning, and I think the worry right now is if we don't get something out there, then it's going to be wildfire on trying what to do and what to decide. So I think the big question that JTS is up against, as we've discussed here, is where exactly does this go? Do we bury it in something like an instruction on how to be a medical director and it may just get lost in translation? Do we have something very definitively that is a CPG or an OPG if we don't have actual clinical-based relevant data to say this is why it's a CPG? Or do we just make an operational planning guidance? Or do we just continue to have these conversations and hope that medical directors eventually have this conversation with their medics? Because I agree, a lot of this can be handled at the unit medical level, but without good NCO leadership, is that happening? I'm going to take that young 03 and I'm going to sit him down and say, hey, hold on to my pocket so you don't get lost, sir, ma'am. But this is what combat looks like, and this is what I've experienced, and here's the moral injuries I've suffered, here's the things that I've had to deal with. This is what you need to be prepared to have a talk with the boys and girls about, because we're going to lose people. But you just got to be able to give them your expectations so they're not disappointing you, so they're not disappointing themselves, so they're not disappointing the commander. And once you have the team buy-in, you have the platoon buy-in, you have the company buy-in, and eventually you have everybody on the same page that, yep, this was medically necessary. It was tactically necessary. It was medically necessary. We have to pull away. That's why Sarge isn't getting treatment right now. But we all have to look at each other and have those conversations and say, we did the best we could with what we had, and we don't have that right now. So I think that's the big push. We gotta find the rose, who to pin the rose on, and where it goes, so we can reference that. And I agree, it's probably gonna be in multiple places. It's gonna be in the PCC guidelines. It's gonna be in the PCC curriculum, the learning objectives as a talking point that we have to teach and get to. But again, to not come up with that's the death CPG. Have you guys read the latest death CPG? We're trying to stay away from that because it's got to be because like you said, medical is medical momentum, right? And Jin talked about it too. We see it in Israel, and we've seen it in Afghanistan too. When the Afghan forces would tell us that they fought harder with us because they knew that we had the medical ass to go there and back them up. So they take a little more chances. They'd go out and run there. But if we put out something that says, hey, we're going to preserve the fighting force, some of you are not going to make it. It might have made it. Today's priorities are tomorrow's expectants. So that's what we have to have those conversations, and everybody, maybe a little bit of, warrior ethos, and just suck it up a little bit and know that we're going into this and we're not all coming back. But we have to be able to prepare ourselves mentally, physically, and spiritually to be able to handle these things.
So I think too that, and speaking for me, I don't care if it's a CPG, a memo, a unit-directed task. My biggest concern is that we are not passing the ethical decision that higher leadership doesn't want to make down to the medic at POI who's going to make it regardless. So we can sit here and turn semantics all we want about what the appropriate channel is, and I think that's a fair discussion. However, we need to ensure that the momentum is upheld and that we have top-level leadership that are willing to make the ethical decision that they are at the same time asking their medic to make independently. Yeah.
And then one thing that I think is true is that after the fact, we can't Monday morning. We have to review it in a responsible way, and then all the physicians in the room need to be cognizant of the environment and how difficult the decision is, and how we get better by reviewing these decisions when they happen, and how we do that. Otherwise, we're going to fail as well. And so that's a physician responsibility for all the physicians in the room. But no matter what your experience is, you need to try to understand the vantage point of the person who's making the decision at that time.
Okay, so with that, definitely want to recognize a lot of the folks who have been working on this. The PFC consortium has already been looking at this for a few years and talking about it, but this is kind of the short list. But real quick, we've got about 5 minutes, so we want to open this up to the audience. Is there other things we need to look at? Do you have questions? Do you have points right now? Let's keep it moving along.
Hey, we can. I think I have the microphone next, so we can take an extra 10 minutes. No, I don't. Oh,
So we can take it out of his
I can
time.
take it out of my time later.
Colonel Lord's here, so we're talking about your kind of work because you're going to get them otherwise.
Yeah.
Basically.
Hey, Stacey Shackelford. Really, really excellent conversation. I just kind of want to back up what the ranger just said. Don't push the decision down. I think if we can take some of the wisdom of the trauma surgeons and put it in a guidance, I think it would really help. And some of it could be data driven. I think what you're really struggling with is there's no like one definition of expected patient. It depends on the situation. So I think what would help in decision making is for people to know the survivability of different types of wounds and an example of what is expectant. So for example, I know we've looked at this in the past. Any patient that requires blood or a ventilator to live during the first hour, if they can't live 1 hour without those interventions, that is a very, very resource intensive patient. And, just knowing that if you need 1 unit of blood during the first hour, you're going to require an average of 20 more units of blood to survive. That can assist their decision making in the scenario. Same thing for me. If I know the patient has a 1% chance of survival, but I have unlimited resources, what the hell, I'll do it. But if it's during a mass cal event, I'm not going to, do an emergency thoracotomy on a patient. And then, just to define, I think the main things is bleeding, ventilator support, and TBIs. And if you could focus on those 3 things and identify which patients, what their percent of survival is. Another example is above knee amputation requires a mean of 8 units of blood. And so that would just help their decision making. And then the second thing that we do as trauma surgeons is we try not to put that decision on an individual. And so the more you can share decision making, even if it's between 2 medics, maybe it's between the medic and the platoon leader, if possible the medic and the doc, but if you can share that responsibility, like this is a no-win situation, we have to make the best of, of what we have left and not put it on an individual.
All right, we got a long line. Go.
Just to follow up on that, 30-year civilian medic, and I've been in a lot of these situations, and where you really run into the disconnect and the problem, and I think the moral injury a lot of times is with the least trained people, with the firefighters, with the EMTs, and I think the more you can, whatever decision, whatever policy you come up with, the more you can take that down to the absolute bottom level and work your way up. I think that more effective that will be tactically, medically, in a lot of ways.
Yeah. I 100% agree with what you're saying, sir, because it's not just going to be the medics that are going to have to deal with this moral injury, whether it's a 68 whiskey that's an E1, E2, it's their 11 Bravos, their engineers, their mechanics that are on the objective or on that mission with them. And so getting that information out to them as well is going to be hugely important, just like we've done with T-TRIC training, understanding this discussion needs to be had outside of the medical community as well, is going to be something we have to start bridging.
Yeah, I also think the onus is really going to be on the medics and the medical directors for expectation management for those guys, because people who have realistically been involved in end of care, it can take 5, 10, 15 hours sometimes for things to happen. So when you're really bad, like neurological symptoms or TBI patients, those could take a really long time. The thing I worry about, I want the CPG. I think it's an amazing discussion. The thing I do worry about though is the moral injury involved in, like, I called this guy expectant at hour 3. He's getting evac to hour 15. He did survive through this. Now he has extreme deficits. So really being able to recognize what is expected and what isn't, and knowing that these things can take a long time. They can be ugly. They can draw out for 15 hours, and it's a very brutal process to watch. So it's really just arming yourself mentally, arming your junior medics mentally before they have to go through something like that. So,
and that's really hard to put in a CPG, what you just described.
And to counter that, I'll just say that, not to counter it, but to respond. I don't pretend to think that it's ever going to be easy. Even if we have topside cover and we define this, it's not going to make the decision easy. But at a base level, it's still about doing the most good for the most amount of people. And as a consequence of that, others are not going to get the treatment that they would have expected even 2 or 3 years ago.
I had kind of a unique perspective. I was at 18 Delta, and then I went to medical school, and I was a hospitalist during COVID. So when we really think about LISCO and overwhelming amounts of casualties, you can take from any major hospital that was overwhelmed during COVID as kind of a guideline. In fact, the VA, which where I work, took the guideline they had for influenza and they altered it for COVID, and they have very specific guidelines on how to do that when we hit crisis of care, which essentially is what we're talking about. When you've got, when you're overwhelmed, your resources and your Class 8 and your technical expertise, you have to try to change that triage category because your evac times change everything and that stuff. So, but I think what we're really talking about is the unique difference than civilian medicine than from us, right? So from us, and Rick mentioned it as well, is the hardest thing about our moral injuries are going to come from treating a person who is your brother, your sister, a person you've known for years. Like, we as hospitalists, as surgeons, as ER people, when we lose people, it hurts, but it's different when it's somebody who your kids play together with, that you treat their wife, you treat their kids, you treat their damn dogs. Like, it's a whole different level. And I don't know if we're ever going to be able to fully prepare for that, but we can't do it if we don't have the conversation. And so I think that having that conversation early in training at the 68 Whiskey School, because these 18-year-old, 19-year-old kids are going to be taking care of 18, 19-year-old kids. And when they're in that CCP by themselves trying to triage, it's going to be a lonely day. And I've been that lonely day medic. And that's why I'm still in, so that I can teach these kids and prepare them. But just like we do our tourniquets at different levels of care, we need to do also our conversations about death and dying. And all the physicians here know we suck at death and dying anyways, right? Like our hospice care, how we train in med school. We go to school for 4 years, and people suck at having conversations about death. And it takes a lot of experience, and that's going to be really hard to convey. But we can't even begin if we don't have that conversation. So I'm really glad we're having it now. I'm taking this back to where I go, but it's an important conversation to have. There's going to be imperfect ways to treat it. But I think that's why having a CPG that just says have the talk. Like, this is have a discussion to realize our commanders. I mean, I looked at the last Center of Army Lessons Learned. They took 11 rotations to NTC on peer conflicts, right? Peer versus peer. And the average death of wounds expectancy was 54%. And we all know that's not real because nobody's actually judging these treatments. They're just doing evac time. That's it. They're not doing a real Class 8 burn rate. They're not actually doing the treatments on the ground. So that 54% isn't even real, right? That's 11 rotations, 11 brigades. So if we don't have these conversations, who's going to have them to convey to our commanders, to give them realistic expectations and take that more seriously? So super glad we're having this. And Rick, I can get you that guideline and stuff you want to look at.
Yeah, absolutely. There's one other conversation that needs to be had with this, in my opinion, as well. It's as we dive into the moral injury, talking about the medics on the battlefield, right? The next conversation is a great one to have, talking about the preventable death and how all these things happen. But we need to also start looking at how we reframe that conversation. Because telling me the medic or the patient I had to put into palliative care was a potentially preventable death also can cause secondary moral injury, because I know I did what was right in the moment, both tactically and medically. But then, oh yeah, you could have saved him. Yeah, maybe if I was in Baltimore shock trauma, but not when I'm in Bakhmut.
So trust us, we could talk about this all day. We have a few times now. So we're up for time. We're around for more discussion though.
Yeah, that QR code, we knew there would be a lot of people that wanted to put out some very important information. That's why we've been putting the survey out. That is your opportunity. We are going to read and collate every single one of your responses. Our goal is to get at least 200 medics to tell us about their experience. This is going directly to the JTS leadership, so please scan that QR code. There were some cards out yesterday. Please give us your feedback. We know there are probably a lot of opinions out there. Please, please, please send us the survey. And the cards from yesterday. There were some cards. Yeah, I don't know if they're.
Because they're out on the table.
They're on the
outside
table.
the door as well. There's a QR code.
We'll be around to answer questions for you.
Yeah, thank you.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.